Uh, Good afternoon, everybody. A greeting from my side. Let me introduce myself. I am Dr. Vikram Goyal, working as a director and unit head in Fortis Hospital, Jaipur, in adult, pediatric, and a minimal invasive cardiac surgery. So, like today's topic is the advancement in the cardiac surgery or the recent advancement in the cardiac surgery. As we all understand, that cardiothoracic and vascular surgery or a cardiac surgery as such is a very fascinating branch. And among the doctors, it's called as the glamorous branch because we deal with the heart. So there is a lot of advancement and lot of hype and talk about the cardiac surgery as such. And moreover, in last decade or so, there is a lot of advancement, fascinating advancement in this particular branch. So, like, let me tell you that what is this cardiac surgery is all about. What we deal. Basically deal with three things. One is ischemic heart disease or a coronary artery disease. Another thing is the valvular heart disease. And third thing is pediatric cardiac surgery or Janjat Hridaya Rog. So, like, let us take one by one every one of these three. First is ischemic heart disease or a coronary artery disease or myocardial infarction or heart attack disease. Like we all know that just the load of the coronary artery disease is like ever increasing, especially in this part of the world where we are living in India. India is supposed to be the hub of the coronary artery disease, and that is very unfortunate. So, coronary artery disease and our mainstay of our practice is naturally dealing with the coronary artery disease, and that is how we deal it. We deal it with the one very fascinating thing which we all know is coronary artery bypass surgery. So basically, bypass surgery is like comprises of 70% of our all practice. So there is a lot of advancement in the coronary artery bypass surgery in last decade or so, and more specifically in last 5 6 years. So one is like in what type of cases we do bypass surgery. Primarily two type of cases. One is like left main disease, and the second is multi-vessel triple vessel disease. So now more and more cases are being, we put the graft in the bypass surgery, and the gold standard way of putting graft or gold standard grafts are one artery, that is left internal memory artery, and then the rest veins, the saphenous veins, and that we normally harvest from the leg. But in the advancement sector, what we have started doing is that using more and more arterial conduits, like left internal memory artery is there, very much there. But other than the left internal memory, we also use right internal memory artery and radial artery and sometimes the other arteries. And that too, in 80 to 75 to 80% cases in my practice, I do Lima Rima Y. That is, from one conduit only we put all the grafts. So this is the Lima Rima Y, and the difference between the venous graft and the arterial graft is there are several differences, but the main difference is that we expect the arterial graft to stay there with the patient patent for at least like up to the tune of 25 to 30 years in comparison to the venous graft when we are worried of those grafts getting blocked in 10 12 years. That's a great thing. Secondly, of course, the off pump or the beating heart surgery, and with beating heart surgery is so prevalent in this part of the world, again in India. So it takes out all the complication or the problems associated with the pump. We don't use pump in a bypass surgery. Hardly we use pump. Then the advancement is that we are now dealing on a very regular basis and very effective basis the complication of the bypass, like the septal rupture or the mitral regurgitation और द कार्डियक रप्चर. कभी हम सुनते थे कि जब हार्ट अटैक आया वो इस तरीके का आया कि समय ही नहीं मिला और आदमी का हार्ट फट गया और हम उनको बचा नहीं पाए. दीज वर द थिंग्स जो होती थी उस समय और होती हैं अभी भी कई कई सेंटर्स पे. लेकिन अब हम ज़्यादा से ज़्यादा इन कॉम्प्लिकेशंस को और इवन हार्ट रप्चर को भी डील कर रहे हैं और बड़े सक्सेसफुली डील कर रहे हैं. वी कैन सेव even the patient who are unfortunate to have cardiac rupture after uh, coronary artery disease. So that's another thing. Now, going further, even more fascinating thing is, and the advancement is that we are using total. We can give total endoscopic coronary artery bypass, which is called TCAR, where we don't do it with a robot or robotic cardiac surgery. So like the instead of the opening the chest and surgeon is standing on the chest of the patient and doing the bypass surgery. Instead of that, we control the bypass surgery with the help of robot. So there are two things. One is robotic assisted, where we harvest lima and the vessels and the other thing, and then we perform the bypass surgery. And the another thing is, the even more advanced thing is that robot doing everything means you control the robot up to the extent that from the word go till the end, the whole bypass surgery is being performed by the robot also. So, like coming to the conduit, the harvesting of vein. You all must have seen your relative or some of your friends being operated for the bypass surgery and having incision in the leg, long incision from the ankle to the even sometimes to the thigh. That is because that we take out the vein. But now what we have started doing is that instead of that long incision, we are using endoscopic harvesting of vein where we don't put any incision. You won't find any incision in that thing, and with the endoscope only, we take out and harvest the vein. So that gives a lot of cosmetic value, as well as the compliance of the patient is much better. Now coming to the another special spectrum of the cardiac surgery is the valvular heart disease. So you see, in human heart there are four valves. Two are in the left and the two are in the right. So mainly we deal with the left-sided heart valve because those are the valves which get damaged easily. So there are two type of valve. One is aortic valve and another is mitral valve. And in both the situation, there is a lot of advancement. And I would say that the maximum advancement in this subspectrum only. So in aortic stenosis, we find more and more cases with aortic stenosis because there is an increase of the life expectancy because of the better medical care and the other facilities. So naturally, we tend to have a lot of aortic stenosis patients because with the age, the chances of aortic wall getting stenosed are proportionally higher. So conventionally, we cut open the sternum by 7-8 inches incision, and we do open heart and take out the valve and then replace the valve. But now, for last 5-7 years, especially last 4-5 years, we can actually give a new aortic wall without cutting the sternum, without even touching the sternum or cutting the bone or putting any sort of incision. This is a special technique, and this is called a TAVI. TAVI means transcatheter valve implantation. So more and more cases we are performing more and more cases we are performing TAVI. So TAVI is a very fascinating thing, very interesting thing. The patient compliance is a huge, and there is a morbidity is like almost zero, and you can do a lot of high risk cases with the TAVI, and the recovery is naturally very fast. And there is a heart team approach in the TAVI where the cardiologists, cardiac surgeons, the anesthetists all are involved, and we discuss before the actual procedure and then perform. And you won't believe that in within less than 24 hours or 36 hours after this major valve implantation, patient goes home. So this is what the quite interesting and quite useful thing for the patient. And mind you, this we do in a local anesthesia. So we don't even give the general anesthesia. This is such a smooth procedure. Coming to the mitral wall also we are performing transcatheter mitral wall repair as well as the replacement. I would admit here that this is in a little infancy stage. Still, we are not mastered it, but the way we are going, I am sure that with the passage of time, we will be able to give it on demand to the patient. Coming to the tricuspid wall, which is the third wall, we also again we are on the right track, and I am quite hopeful that we will be able to deal the tricuspid wall. One here, I would like to add one very important thing, that is valve in valve. Now, this valve in valve is again a very useful thing. Valve in valve means that even if your bioprosthetic valve or valve which was being put say like 5, 7, 10 years ago, so you need not to go a redo surgery, right? We with the TAVI or transcatheter, we can implant the valve in your already damaged valve. So like we can save you with very little morbidity. So right, this is again a very good thing, and practically this valve in valve is quite established now. We have got lot many, data available for the valve in valve and being routinely performed in many centers, including ours. So now this is about the valves. Coming to the pediatric or congenital heart defect, this is the vast subspecialty, and for personally, I am very fond of this, and this is very close to me. Here, I would like to just add one thing, that there were a lot of complexity. There is a lot of complexity associated when we talk about the pediatric or infant cardiac surgery and congenital heart defects. And unfortunately, there are very few people, few doctors, few surgeons who are performing this congenital heart defect, especially the complex one. So, like I just mentioned, that I am very fond of complex congenital heart surgery treatment, because this gives us the immense pleasure and satisfaction, because you give like 50, 60, 70 years of life to a person when you to a kid when you perform this surgery successfully. So the only thing is the advancement is so much now that practically we can deal every type of complex congenital cyanotic heart disease defects. Maybe it's only a 1 day old kid. Even in home also we are performing the cardiac surgery, but right from the birth, like from the first breath, we with the having unfortunately a kid having congenital defect, we are doing it, and we are doing it regularly, and many people are doing it. So now again there is another advancement which I would like to touch upon or mention, is the mechanical circulatory support, which everybody is hearing a lot about it, especially in the recently gone past era of COVID, that there is a mechanical circulatory support, especially in a heart failure condition, when the heart is totally failed and the functions are very poor. In that situation, the ultimate treatment many a times is like heart transplant. Now, heart transplant is a one thing which gives the full therapy or full treatment. But unfortunately, the problem with the heart transplant is that there are very few donors available still in this part of the world. And so while waiting for the heart transplant or donor, many of our patients succumbs. So during that period, or during the waiting period, or sometime for the recovery also, there are a lot of mechanically circulatory support, especially useful in a patient with a end stage heart failure. And there are two type of circulatory support. One is short-term circulatory support, and the other one is the long-term circulatory support. So short-term circulatory support for some day, sometimes, some days, a few days, like Tandem Heart, Abiomed, Impella, then CentriMag, HeartMate. These are the few short-term supports. In the long-term support, you need to have pulsatile flow. You have got a nowadays we have got a third generation long-term support like Jarvik 2000 and and different type of these. I won't go much into the technicalities, but the the point is that we have got a long-term mechanical circulatory support in an end stage heart failure stage, so that we can prolong the life of the person, the patient who is having this dreaded sort of a problem. Now coming to the assist device, this is another again a very special sort of a devices which has come up from the immense effort by the scientists as well as the industry, and we have come up with those assist device which will assist the ventricle or a failing ventricle, and that too specifically of the ventricle. There are two ventricles, as we all know. One is right ventricle, and another is the left ventricle of the human heart. So there are right ventricle assist device as well as the left ventricle assist device, and there are also the biventricle assist device also. So by putting them, by implanting them, and that's a very easy, we can prolong the human life and very effectively. So this is assist devices are very important advancement, which is uh, which is give us the opportunity or the options of making the person's life happier, healthier, and longer. Now another thing which is like the real advancement, and which is again a extraordinarily beautiful thing, and is the closest to my heart, is like minimally invasive cardiac surgery. Like minimal invasive cardiac surgery is the real advancement in my mind, because this is the one thing which takes away all the things which we were from the open heart surgery, which we used to be worried about. Like in minimal invasive cardiac surgery, what we do is like in comparison to the conventional cardiac surgery, where we put 8 to 9 inches incision in the middle of the chest, and then splitting the sternum, the bone, into two, and spreading the sternum apart, and do the open heart surgery or bypass surgery or valvular heart surgery. And then after completion of the procedure, we tend to put a sternal wire to approximate the bone, and then healing take place. So in minimally invasive cardiac surgery, we don't give that sort of an incision. We just put 2 inches or a 2.5 inches incision on the right sided or left sided of thorax. There is no incision, no big incision, and specifically there is no incision on the middle of the sternum. And there is no bone cut. Because there is no bone cut, then there is no issues of the external wires. The healing is very fast, and actually the patient is being discharged on a third day or a second day or a fourth day of the surgery, and there is absolutely no scar, especially in a female. This is an absolute boon, because the incision, the 2 inches incision, is just some memory. So even if she won't be able to notice. So that's the great thing, especially the corporate goers, or the females, or for that matter anybody. The minimal invasive cardiac surgery is the most fascinating thing, and I must tell you, and I take pride up in this big time. And with all modesty, I would like to say that I have been doing it for 18 years. So this is like one of the you know the thing which is very close to me, and now we have reached to that level that we can actually give it to every patient, almost every patient of all type of spectra, CABG, pediatric, minimal, valvular, on demand. And naturally, we can understand the smile, the recovery, the smile on the face of the patient and the relative, and the recovery is so fast that actually you can resume your productive life in less than a fortnight. 15 days, you are going back to the office, you are going back to your work. So that's the great thing, and there is a real advancement about this thing. And as I've told you, just informed you that we are giving it on demand nowadays. So this is again a good thing, and there are so much less chances of infection. The bleeding is almost negligible. So I can safely say that minimal invasive cardiac surgery is here to stay and here to flourish. So these are the advancement of the cardiac surgery which are coming to my mind right now. I'm sure there must be some few others which I'm forgetting right now. Yeah, another way is like aortic surgery, where we are not doing any surgery nowadays, but just putting the endoscopic repair for the aneurysm and dissection. So cardiac surgery is like ever progressive and ever improving branch, and I'm hoping and that the progress and the advancement will keep on happening, and will happen with even with more vigor and speed. And let's hope for the best. Thank you very much. in case